All righty, and we're live. Welcome, everyone. Happy Monday. Today is Mindset Monday, and I have the privilege of having this fantastic panel of providers here in honor of Obesity Care Week, and tomorrow is World Obesity Day. I have with me Dr. Bemberheim, Dr. Tischler, Dr. Shapiro, Dr. Dugan, and Dr. Umashankar. So welcome aboard, everyone.
Thanks for hosting this, Amy.
Yes, so Dr. Tischler, I'm going to hand the podium over to you, the
Excellent.
metaphorical podium, and you can guide us through this evening.
Well, thank you, Amy. Thanks, everyone, for joining, and to my partners, colleagues, and everyone. Really excited about this. World Obesity Day and Obesity Care Week is an opportunity for us to really talk about obesity a little differently. We talk about obesity every day as a disease. We talk with our patients about obesity. We talk about the direct impacts of one person. Today, we're going to talk a little bit more about how obesity affects us as a society and how we want to think about obesity. And we're going to get you'll get a little glimpse today of some of the kind of inner workings of what we do, the kinds of conversations we have on a regular basis to help to improve the care of obesity, access to life-saving treatments, and really to help reduce the stigma and shame that can go with obesity. So I'm going to start things off right away. I'll start with Dr. Shapiro here with our first question. And we're just going to talk about a variety of topics here today. So, Dr. Shapiro, in many cases, obesity is seen as a personal failure. It's that someone wasn't able to have control over their eating. Maybe sometimes people are told by their healthcare providers, family, or friends, you just got to try a little harder at this to make the weight go away. Help us understand what we can do in healthcare as a healthcare community to help to almost shift that perception.
Uh, so, um, yeah, I think there really is an issue in the country around the stigma of obesity. I think, obesity itself is really a medical condition, and it's multifactorial where obesity comes from. It comes a lot from, the way you were raised. It comes from genetics. It comes from how you eat. It comes from, the environment where you live, and, the foods that you choose and the foods that you were introduced to as a child. And I think when we see adults that are obese, there's really no going back to changing the way someone was raised or changing genetics. At that point, when the patients come to us and people come to us, they have a disease and they're asking for help. And I think it's not helpful for practitioners to suggest that patients just eat less, because we know that as physicians, just eating a little bit less doesn't lead to massive weight loss. The people that come to us for help, need to lose sometimes 50, sometimes 100, sometimes more pounds than that. And you can't do that with diet alone. So I think that's where we come in as a team. We have a multimodal team. We do address diet, we address exercise, and then we address, the possibility of using medication. And we also offer surgery. So we offer a wide range of options. And I think it's important, for medical doctors out there to realize that obesity is a disease. It's not treated just with diet. It's treated with medication. It's treated with surgery. There's other options out there, and it is something that is treatable.
Thank you, Dr. Shapiro. And I should have introduced Dr. Shapiro before. Dr. Shapiro is our medical director for our program at Bacchus Hospital for bariatric surgeons, one of our bariatric surgeons. Dr. Umashankar, our director for obesity medicine, our non-surgical arm of our program. With the same question here, just trying to get a little further on this topic. What do you think needs to be changed in healthcare? What are the urgent things that we need to do to help really change the perceptions about treating obesity as a disease?
So thank you, Darren. I think Actually, since even though in 2013 AMA officially diagnosed obesity as a disease, I don't think it's really moved the needle as much as we would expect in terms of the treatment of chronic diseases, because we still see that a lot of people don't use bariatric surgery, which is the gold standard of treatment for obesity, and there's a lot of hesitation even around medications. So I think when we think about, what really needs to be changed, what's the urgent matters that need to be taken care of hand, I think it's really comes down to increasing education with our physicians and our clinical providers, really sharing with them the utility of these different treatment options that they have for patients and bringing it up in conversations with patients sooner than later. I think it's very different when we have patients who we see with a BMI of 40 at a younger age versus a BMI of 60 or 70. And I just think it really comes down to that education piece with our primary care providers or other subspecialists.
Thank you. Dr. Bebrahim, our medical director for Midstate Hospital, our central region. Help us understand how we can change the public perception about obesity. What do you see? You've got a lot of experience in this. What do you see as some of the misperceptions from the public and family members and friends of patients when it comes to treating obesity?
Thank you, Darren. Thank you so much. Well, it comes back to what Dr. Mashankar just said and Dr. Shapiro. It is a disease, and we are trying to explain that we don't do this for people who have cancer. We don't do this for people who have diabetes. A diabetic, we have seen people eating a lot of sugar and chocolate. They don't have diabetes. However, that's a hormonal problem and similar for obesity. The stigma is there, the failure patients feel is there, and I think it's up to the providers, to the physicians to tackle this, not to have any fear to say, hey, you have a disease, we have ways of treating it, and that's really what we need to hammer all the time. We have to respect our patients and we have to respect their disease.
Yeah, I really appreciate what you said about we don't do this for any other disease. And I think, we're going to talk a little bit more about education in a few minutes, but, I think education does play a significant role here. I'm going to get to our other providers in just a minute or so here, but I want to just ask Dr. Papasavas a question. Dr. Papasavas, speaking of education, is in the middle of another meeting with our residency program right now. He stepped out for a few minutes to be with us, but he's also our director of surgical research. And Dr. Papasavas, from a research standpoint, where do you think we're going to see some of the most impactful changes when it comes to either education or talking about the stigma of obesity or treating obesity as the chronic disease that it is?
Yes, thank you, Darren. Our program, our research program, and others have done research on the stigma of obesity and how it impacts patients' efforts to lose weight. So when a patient is exposed to stigma, a lot of times this is internalized. So this becomes part of their DNA, and they feel shame for having a disease. And this sabotages their effort to lose weight. We know that people who have internalized the stigma as not as successful following a diet or even after surgery. So it's a very important topic right now. The national meeting in June is dedicated to weight stigma. We have done studies. Dr. Omashaki was involved in several of them when he looked at stigma before and after surgery. Right now we're doing a study on residual stigma, so how people are treated after they lose weight with surgery or medications. Do they receive different behaviors from their environment? Do they get more job opportunities? Are people nicer to them? And if they see this change in behavior because they change how they look, that can be hurtful. That can, really hurt the feelings because they're not evaluated for what they are, but how they look, and they're judged. So there's a lot of work that needs to be done. We are at the forefront of this. And we'll be, hopefully we'll be able to share a lot of our findings in the near future.
Thank you, Dr. Papasavas. I think it's such important work that's being done, both worldwide and what's being done here at Hartford Healthcare, really looking at this topic. For Dr. Dugan here, our medical director for our Fairfield region or St. Vincent's Hospital, what have you seen on how patients are affected by sometimes the hurtful comments they might receive, and how it affects their ability to approach you in the office? We have well-trained teams that I think we offer a very caring and welcoming environment, but for our patients, but there are barriers that are there. And what do you think some of those barriers are that our patients face when they're coming to see us because of what they've experienced in their life?
So that's a good question. One of the common barriers is actually friends and family, to be perfectly honest. I've had many patients express to me that their family members don't support their decision to pursue weight loss, medications, or surgery. They look at it as cheating or an easy way out. And I've had some patients actually be, persuaded not to pursue either surgical or medical intervention because of friends and family speaking to them in this way. I've also had some patients express to me that their communities weren't very receptive. And even though they weren't telling them that they were necessarily having surgery, they assumed because of the drastic change in their weight in a short period of time that perhaps they had done something, and they were receiving a lot of negative feedback even without openly discussing their weight loss journey. So I think that's probably the most significant because it's the most hurtful, because these are the people that you rely on for support. And so I think one of the very first, stigmas that we have to change is that we have within our closest communities, and including our friends and family.
Thank you, Dr. Dugan. I agree with everything you said there. I think we all see patients who come to us who have their guard up. There's barriers, emotional barriers to talking about obesity. There's a fear of coming to see someone for that very first visit to talk about obesity. Personally, the most important question I ask anybody who wants to come work in one of our programs, when I'm interviewing someone, is, are you comfortable working with people who have obesity? And I start the dialogue from that point. And I think it's an important question for us to ask. But I want to peel back some of the layers here about what we do in our office. What you see, kind of what people see kind of behind the curtains here. For Amy, what kind of stuff do we do to really help our staff and everyone who interacts with their patients feel more comfortable having these sometimes difficult conversations about obesity as a disease? Our patients are always, I think sometimes on that first visit, it's a very fragile visit. Our patients have come up with that courage they need to treat obesity, and we have to be there to really be ready to go when the patient gives us that opening to help them with their obesity. What kind of things do we do with our team to really help them be ready to help our patients?
So I think that you mentioned the number one thing is we choose team members who are inherently kind and comfortable interacting with any number of types of patients. In addition to that, we do a lot of education with our team members about sensitivity education. It's a requirement, but it's also an excellent way to educate our team so that they can understand how every interaction we have with a patient is meaningful. You mentioned earlier that sometimes patients, it takes courage for them to come to us and have these difficult conversations. And if we receive them from the moment they walk in the door at our front desk with kindness and understanding and that makes every further step through the process just so much easier.
Thank you, Amy. One of the things that we've really worked on the last couple of years is our ability to reach out to a variety of populations that might not feel comfortable coming to see us. In particular, our Spanish-speaking patients. So many barriers there. And we've done a lot of work to get to that point. It was everyone here knows about this, but I presented this topic at our state chapter meeting, and I had to do a lot of reflecting on what it is that we did to get to that point. And I think it comes down to, as you said, Amy, having the right people who are willing to help take down some of those barriers, because there's little things that we do that make people feel comfortable. Having someone that speaks a patient's language, someone that understands their unique culture, having furniture where a patient feels comfortable. They don't feel like the chair might break. And sometimes patients notice this. Sometimes they just feel comfortable because of all these things that we do. For Dr. Shapiro, I'm gonna can push us forward a little bit more with this topic of education. And one of our goals in Hartford Healthcare over the last year has been to start to figure out what else can we do to help educate people on the disease of obesity. And by people, I mean everyone. I'm talking about people who work in healthcare, people who treat obesity, people who have obesity, and family members or friends that don't suffer from obesity. Where do you think we need to go with education about this disease?
I really agree with Devika. I think it's really important to get our fellow physicians to become comfortable with bringing up the idea of obesity and the disease of obesity and options for treatment. I have gone into a lot of offices recently of, primary care doctors and, orthopedic surgeons and pulmonologists, and a lot of these people, they say, we have so many patients that could really benefit from your services, but it's just uncomfortable to bring up the issue. And so, we've been trying to do education around, how, people might become a little more comfortable. I mean, when we look at obesity, it is a number and it's about comorbidities. And I feel like, if we talk about hypertension, we talk about cardiovascular disease, we talk about osteoarthritis, and we don't mention the fact that the patient or the person in front of us has a body mass index of 50, that we're really doing them a disservice if we're treating all those other problems and we're not treating the obesity. And so I really, ask that physicians out there realize that, to not mention obesity is actually not helping their patient, it's actually hurting their patient, because we've noticed even with medical weight loss now, there's regression of all of these different obesity-related diseases. And so, instead of just treating the hypertension, we could be treating the weight, and we could be treating the hypertension, we could be treating the obstructive sleep apnea, we could also be treating the diabetes. So, you get a lot of bang for your buck when you treat obesity. And I think that's something that other physicians need to start to kind of embody and realize.
Thank you, Dr. Shapiro. And I'm going to carry this conversation a little more forward with both Dr. Benbrahim and Dr. Papasavas, because they also recently presented about some new ways to think about classifying obesity. Dr. Papasavas, why don't you talk to us a little bit about some of what the article from The Lancet that came out just in the last couple of months about how we define obesity?
Yes, Lancet Diabetes is a very prominent scientific journal that established a consortium of scientists around the world with a task to define obesity better. Because right now, what we use to measure obesity is the BMI. BMI, body mass index, is a mathematical calculation. The definition of obesity is excess fat in the human body, and BMI does not measure fat. And it's a very good proxy of obesity, especially for BMIs over 40. You're pretty certain that this person has excess fat in their body. Where it is not very accurate is when the BMI is between 25 and 35. This is where you may have somebody with a normal BMI of 25 or 24, but they have more fat than they should. Or you can have a BMI of 29 and they have so much muscle, so they have an abnormal BMI, but they do not have an obesity disease. So measuring the fat with several means. There are bioelectrical impedance scales. So these are the scales you step on, and it gives you an estimate of how much fat you have in your body. There are more scientific ways of doing it, like the DEXA scan, but also like a simple measurement of the waist circumference. Just take a measuring tape and put it around your waist. That sometimes can supplement what the BMI gives you regarding the distribution of the fat in the body. And this is important because where the fat is in the human body makes a big difference. If the fat is in the lower part of the abdomen, the hips, the legs, is not as bad as when it's in the abdominal area, especially within the abdominal cavity, what we call visceral fat. So this is the effort about defining the obesity differently. And then, Aziz may want to talk about the clinical obesity and preclinical obesity concept.
Well, you saved me from asking the question. So, Dr. Benrahim, why don't we jump right into that? Because a major part of what we think about on a daily basis is whether somebody is healthy or unhealthy, and obviously, it's one of the most important things about treating disease. I think today we see so many ads on television, the internet, on social media about new treatments for obesity. But as physicians and healthcare providers, I think one of the most important things we do is look at people in terms of, is there a health problem that we can improve? So talk to me a little bit about this concept of clinical obesity and preclinical obesity. I think another terms we can use are patients who are metabolically healthy or metabolically unhealthy individuals.
Yeah, thank you, Darren. And Dr. Papasava said it right. In a way, let's say in America, we're like 300 million people. 10% may need surgery or may need aggressive medical treatment based on only the body mass index alone. So we are talking about, we cannot do 30 million surgeries or so. So the idea from the Lancet came from this concept. Who are people who will really treat aggressively versus people we want? And that really goes along with that movement of, oh, I have weight, but I am not sick, and this stigma against me is not all right. Don't look at me like just a case or so. So this idea came in of, if you have obesity, but you don't have the impact in your organs yet, you don't have diabetes, you don't have high blood pressure, you don't have hypercholesterolemia. So we are in that preclinical side, and it's great to do healthy diets, it's great to do exercise, but then as soon as you shift to the area where your organs are being hurt, then we will have all the resources to treat you effectively.
Thank you, Dr. Benrahim. And for Dr. Umashankar, kind of a question a little bit related to what we talked about earlier today. We're talking about education, and obviously in your specialty, obesity medicine. Now, we're all take care of obesity, and we're all obesity medicine. We're people who treat obesity from a medical standpoint and a surgical standpoint. But what is important right now? Because I know there's a lot of misinformation out there today about some of the medications that are available, and help me understand where the big things we have to educate people on.
So, Darren, I think one area that we need to educate our patients or individuals on is that there's been so much attention on these injectable medications that many times they think that this medication will solve everything. I think individuals don't understand that these medications, these newer medications, where honestly, in the last 3 years, there's been so much more attention on obesity medicine than previously, especially with medications, is that these medications still need to be aligned with lifestyle modifications. These medications do not work for everyone. It is not for everyone. But it doesn't mean just because the newer medications do not work for you, there are not other treatment options that are available. You can always go back to oral anti-obesity medications if surgery is not an option. And if surgery is an option, it's something that one should consider pursuing, because these medications, especially with so much insurance restrictions that are around it right now, it doesn't mean someone will be on it for long term. And what does that look like in terms of fragment care when patients don't receive it consistently? Unfortunately, that's where we are right now in the real world setting. And these are the things that I think we need to educate our patients about.
Thank you on that. And Dr. Dugan, and any thoughts about that from the surgical perspective? And specifically, we talk a lot about multimodal care, that with a lot of diseases that we talk about, we never look for just one treatment, look for the combination of treatments that gives the best result. When we're treating blood pressure, can't use just one medication because you get the side effect of that one medication. But when we use 2 or 3 medications at lower doses, you get a little bit of additive effect from each treatment, and then overall better control blood pressure. So from those kinds of lessons and from what Dr. Umashankar talked about, talk to me a little bit about multimodal care involving bariatric surgery and how it's changed what we do in the last few years.
Sure. So, yeah, I mean, having these medications available has kind of opened the doors to having a multimodal care approach outside of just surgery, but also outside of the medications and surgery in combination with mental health, nutrition. We do have dietitians and psychiatrists and psychologists that also help as well. So all of these components are important. Specifically to medications and surgery, as far as multimodal care, the easiest comparison is to think about, the way I like to think about it is like cancer treatment. We sometimes do surgery on patients with cancers and it can be curative. Sometimes patients just get chemotherapy or radiation. Sometimes they get both. Sometimes they get the medications or the treatment before surgery, and sometimes they get it after. And we're starting to see patients do well with kind of individualized approaches. Some patients, especially if they have a very high BMI, may start on a medication prior to surgery in order to help them lose weight and improve their safety profile. Some patients will be successful just on the medication, but I have a lot of patients, especially higher BMI, that actually end up needing both afterwards. So if we do a sleeve gastrectomy and a patient's plateau still in the BMI above 35, especially in the 40 range, we talk to them about adding medications, and we see a lot of success. And even some patients, like you said, maybe they didn't tolerate a medication before the surgery, such as these injectables. I've seen patients tolerate them much better after having had surgery because of the altered anatomy. So we have a lot of options, more today than when I first started, in medical school or residency, for sure. So it is kind of an exciting time to be in the obesity medicine field.
Absolutely. And Dr. Papasavas, from the research standpoint, where do you think some of the big gaps are when it comes to really understanding multimodal care? Because I think one of the common misconceptions is, if a medication will give me, I'm just going to make up numbers here, okay? Medication should give me 25 pounds of weight loss, and a surgery should give me 75 pounds of weight loss. If I add the two together, I got 100 pounds. But we know that's not correct. Where does the research have to go to help us understand what's the best way to treat this disease?
Yes. So the bariatric surgery offers a great model to do research because you have an event, which is a surgery. So everything involves as before surgery and after surgery. With medications, is slightly more challenging, especially today where these medications are still expensive. They're not covered by insurance all the time. So you may, if you do research, you may want to, look at somebody who started medication, but then you have to have good data. Did the patient take the medication for how long? Did they change the dose? And so this makes research on the effect of the medication very challenging. all these studies that came out with very good results, these were very controlled studies where patients were given the medications by the company, so they provide the medication. So they do not necessarily represent real world data, what happens in the clinical practice. In our program, we have established a prospective database to collect data on patients who take medications, and hopefully this will allow us to do some good research on the multimodal treatment of obesity. We have patients who start medications before surgery, after surgery. There is not like right now an algorithm or a guideline, so everybody's doing what they think is the best for the patients. The good news from all of this is that, like my colleague said earlier, we have more choices. And this is a disease that we can attack from more angles. Surgery is going to be, a very effective treatment. Medications are more effective than ever before. And as long as they prove to be safe in the long term, this can be a first-line treatment for a lot of patients. So the future is bright for patients with obesity, and I hope that we also talk a little bit about, preventing the disease, because you have great treatments, but, it's also very important how to prevent the disease from occurring.
Well, thanks for bringing that up, because that was one of my questions for later to get to, is talking about prevention, but we'll talk about it now. With anything that we treat in medicine, we always have to think about prevention. Okay. We can treat cancer, but we can also work to prevent cancer. Almost anything in medicine, we can talk about prevention. And so let's talk a little bit about where some of those areas are, and where do we start with preventing obesity? And I'm going to be honest, I think that is the more challenge. I think medications, new surgeries, the research we do, that's a bit easier than prevention. So, Dr. Umashankar, where do we have to start with prevention of obesity in the first place?
So I think it comes down to, when you think of preventive medicine in terms of obesity, I think it comes down to nutrition, and I think it comes down to exercise. And I think we have to be very intentional in terms of nutrition and exercise, in engaging young patients that have family history of obesity or themselves are getting onto that trajectory of weight gain, getting them engaged, seeing a dietitian, getting them engaged in exercising, doing community-based programs. It starts in the school settings. That's where I think really comes down to it. And then it goes to the pediatricians. And from there, it evolves with preventive medicine coming to the adult world. I think
So
go ahead.
Thank you, Dr. Umashankar. I'm going to challenge Drs. Dugan and Dr. Shapiro here on this. Both of them have young families, and sometimes the way we think about preventing obesity might actually lead to more stigma about obesity. What do you think, as you're raising kids, are some of the things that you need to be cognizant of? I'll start with Dr. Shapiro first. What do you have to be cognizant of to make sure that while working to prevent obesity, that you don't actually stigmatize the disease and make your kids excessively worried about it? Because sometimes the language that we use and how we talk to our kids about obesity can actually have the opposite effect. So I'm going for my parents of young kids here. Dr. Shapiro.
So I agree a lot with what David has said, is that I think it really does come down to education about nutrition. I think, everybody has health classes in school, and I feel like, what I got out of the health class was like, barely anything. And so in my house, my son, actually, he's 4 years old, but he knows which foods have protein in them. And that's really what we stress getting in every meal. I'm a vegetarian, so it's important to me that I find protein in other ways. I mean, I love snacking on like bread and crackers and different things, but I try to make sure that at least 2 meals out of the day have some kind of substantive protein. And so that's what I stress. And then we also stress trying to eat like some kind of vegetable. We don't talk specifically about amounts, and my son does get to get treats and stuff in the evening, but he has to finish his vegetables. I know there's a thing about, a lot of people saying that they didn't like the fact that they had to finish their whole plate. And that kind of led to possibly being overweight, maybe because they had large portions on their plate when they were growing up. But when I say finish my plate for my son, I usually mean finish the vegetables. And vegetables aren't usually a lot of calories, but they have vitamins and fiber. So.
Dr. Dugan,
Yeah,
how do you incorporate or what do you think you're going to do to help make sure that your kids will eat healthy and have healthy habits to help prevent obesity? And how do you think you're going to address those? And I'm sorry, I'm challenging everyone today here on this, so it's hard stuff we're talking about.
I think you have to, lead by example first. So if they see you eating healthy foods and making good decisions, then they're likely to grow up looking up to that lifestyle, because most kids mimic and imitate their parents, at least at a young age. I think it's also important, though, not to be overly strict where you just outright forbid them from trying anything or having any sort of treat or dessert, because then they're gonna, once they get out of the house, they may have an unhealthy relationship with food, and they might overindulge later on in life. So I think it's about teaching balance, and it's okay to have a piece of birthday cake on your birthday, and if you're going out for a special occasion, to have maybe like a juice or such. So we don't allow juice in the house, but if we're out, we will let her order a juice. My daughter ordered a juice, at dinner. We do tend to cut it with water, though, just because they tend to be very sweet. So we don't want her to necessarily get too much of a sweet tooth, but she enjoys it even when it's cut 50-50 with water. So, because it is very sweet to begin with.
Yeah, and there's one of our little experts there on eating his vegetables. I saw. See, we're all about families here, and that's important. And not only do we have our families at home, we have our patient families as well. And I think it's important that we do also lead by example. And it's true what Dr. Dugan said. It's very easy to create stigma around the disease of obesity. You can't punish people. You can lead by example. I think it's just such important things. And then teaching people the value of how to identify foods, engage your kids in shopping with you, help them pick the healthy foods. One of the things that we see with our patients a lot of times is after they have surgery or they're on new medications, the foods that they loved somehow don't quite taste as good. They find flavors to be too intense. And that's something that's very intentional by the food industry. The food industry makes foods that have almost, I would say, unnatural intensities of flavor. The flavors are much stronger, and patients notice this after their bodies change a little bit, either from medical treatment or from surgical treatment of obesity. So let's see. One of the next things I want to talk about is the connection with behavioral and mental health. There's so many areas that intersect with obesity, and there are tight connections between mental health, mental wellness, overall wellness, and obesity. Dr. Ben Brahim, share some thoughts about this. How can we help at a really as a system level, society level, to help really work through that connection between mental wellness and obesity?
Well, thank you so much. Well, first, let me start with somebody who has a disease, a real disease, and treated with medications. And there are so many medications for psychiatric disease that will increase the weight by themselves. So that's really one thing, which is man-made. And then a patient with severe obesity, as we know, with all the stigma and with all the segregation at every level, obviously creates a psychological situation that needs to be taken care of. And then we have the other side of psychology or psychiatric disease like binge eating disorders and so forth. These are also have to be taken care of prior to our treatment or in parallel with our treatment. So I don't see any treatment for obesity that cannot go in parallel with psychological support.
Yeah, Dr. Umashankar, you work with medications to treat obesity. And so we have medications that help people to lose weight. But part of it's also, I think, looking at the medications that cause people to gain weight. Can you talk to us a little about what happens with some medications in weight gain? I like to term it sometimes the irrational weight gain or the irrational hunger that people can get. They can't understand why they are so hungry and why they're gaining weight on some medications. Help us understand that a little better.
I think, as Aziz mentioned, there's many times with our patients where they're on weight promoting medications that they don't even know about. So for example, some of the times our patients struggle with sleep and they can be put on a weight promoting medication like trazodone or Seroquel. And they feel like without these medications, they don't get the type of sleep that they need. And that's where it's that fine line, because we talk about how we need good sleep hygiene when we're trying to lose weight. But then what do you do when they're on a weight promoting medication that gets them that sleep hygiene that they need? So I think as an obesity medicine specialist, I think our job is to recognize what medications can be titrated down, what medications need to be removed, and what medications are required to stay on. But how do we add some medications from the weight loss world to help assist and promote and optimize their weight? So I think, many medications that we don't even recognize that could have weight promoting effects is, I see gabapentin a lot. I see Lyrica, nortriptyline that helps treat migraines for many of our patient population. And I think that's where when you work with your specialist for weight management, it's really important to go through that list and really be able to understand what we can and cannot do with those medications.
And I think this is a big difference between what this group of providers here, plus all of our other colleagues, on what we do versus what you can get if you go online to get a medication. Because we're looking at this from a bigger standpoint. And I think a lot of times the medication is the easier treatment. And I'm not talking about obesity medication. I'm talking about for a lot of diseases, and especially behavioral health, medication can be the easy way. You take a pill, feel better. I don't personally believe there should be medication for mental health that does not also involve some sort of therapy. Same goes for pain management. And we see it way too often. Patients on longstanding medication that promote weight gain without having that therapy component. And I think it's one of those barriers we have to work to break down. I think we can all do better at educating our patients all the time about the need for is it medication or is it medication and therapy? And what's the goal to come off of a medication? You mentioned Seroquel, Dr. Umashankar. It's used for sleep a lot, okay? It's effective. People fall asleep on Seroquel, but it's a big medication, I think, sometimes for sleep. And sometimes we don't look at the root causes for poor sleep hygiene. Things like we're so overstimulated with electronic devices, we take our phones and our tablets into bed with us, and our brains are just too stimulated sometimes before we go to bed. And I think there's behavioral things that we can do. And again, I don't want anyone to think they should come off their medications. I don't want to give them misinformation here, okay? But I think we have to look at, are there alternatives to medications sometimes, especially medications that can really promote weight. Such an important concept there. Well, we're running short on time, but I want to go through the group here. And I'm going to start with Amy here. I'd like each of us to give one of the myths or misconceptions that we see when it comes to treating obesity. So, Amy, for you, what is one of the biggest myths that you come across and you have to help patients or family or the community understand?
I think it's that myth of, well, you should just try harder and you should just eat less and exercise and it will magically happen for people that and how that relates to patients that we handle, that we take care of, that they come to us having heard that message for years and years and years. And our job is to reassure them that, yes, those things are important tools of this journey, but having surgery or using medications or both is a very viable way to go as far as treating the disease of obesity.
Dr. Dugan, one of the myths that you come across in a regular basis, and you feel like you're talking about it all the time.
So one of the myths that surgery is the easy way out. Ask anybody who's had the surgery. It's a journey and it's a challenge, and it's definitely not an easy quick fix. There's a lot that goes into before and after, and it's definitely not like a quick fix or cheating, as what I guess some would call it.
Mm. Dr. Shapiro, what do you think? Myths, misconceptions, things that you feel like you just want more people, healthcare providers, to know about obesity.
I was going to say that surgery is the easy way out also. But I think, that, one of the myths is that, obesity is something that, kind of happens to people because they're not working hard enough. And, I think that everybody needs to get involved in the treatment of obesity. And even after patients have surgery or patients are on medication, that's not the end all. Patients require consistent support. The patients who do the best in our office are the ones who follow up religiously, every year, and sometimes even more frequently. We go over, see the patients, go over the medications, we go over their diet. I think nutrition, our patients do the best when they follow up regularly with the dietitian, because it's the adherence to the dietary plan after surgery that I think is really the most difficult thing. Sorry, my son's.
That's okay. Dr. Ben Brahim, that misconception that you just wish more people would know about.
Okay, as usual, a provoking thought, and then I know Dr. Umashankar will support me. The myth is that your primary care knows a lot about obesity treatment. Our students in medical school have only 4 to 5% of the in their curriculum talking about obesity and the disease. So why am I saying this? We need to challenge our physicians also. If I am a patient, if you really know exactly how to treat me, otherwise there are specialists to do that.
Excellent. Dr. Umashankar, myths, misconceptions.
Okay, so one of the most common misconception I have that I hear all the time in my world with medications is that you treat obesity and it's more of an acute condition. So once you lose the weight, you can get off the medication. I think what patients should understand is obesity is a long-term treatment. It is a chronic disease. Not to say that when you get on these medications, you have to be on it forever, but there is a certain amount of time that you should consider being on it, even once you've attained your weight loss goal, and then slowly titrating it off once you've optimized your weight and you've reduced your weight-related comorbidities.
So I guess what you're saying here is that once you, I know we hate to use the word goal weight, we hate that, okay? But once you get to that health goal,
Yep.
where you feel better, you're healthier, that's not the end.
Correct.
It's kind of just the beginning there at that point.
Yes.
Dr. Papasavas, for you, the myths, the misconceptions.
One of the biggest misconceptions is that what is portrayed by media as healthy is not necessarily the picture that we should portray. And it's a trap for young people. BMI was not based on any good science. So having a BMI of 25 and above automatically puts half of the population having an abnormal weight. So we call half of the population having like an abnormal weight, which is not okay, especially for young people when they look at what is portrayed in the magazines, in the media, with the fashion models. that's not very healthy. For the mental health is not healthy because they're getting in the trap. They're trying to very hard to lose the weight, and that should not be the focus. Weight is just a number. The focus should be what Nick said earlier. Adopting a balanced, healthy diet. You need to have your carbs, you need to have your fat, your fiber, your protein, and also a healthy, balanced lifestyle. Sleep deprivation is huge for obesity. The same with stress. We live in an environment that is very stressful. So take a few minutes every day from our time to dedicate to ourselves, to do a little bit of physical activity, to do a little bit of mindfulness, to decrease the stress, to value the people who are around us. The Mediterranean diet that everybody says is very healthy is not just the food, it's the way that people live their lives. In small communities, they interact more with each other. They take the time to eat their meal or drink a coffee. They socialize, and that's what we're missing from our lives. So take care of ourselves. That would be my message for tonight.
And for me, the myth that I'd like to talk about a bit is that, well, treating obesity is not for me. We all know people who are heavier than us and people who weigh less than us. We all know people who have more money than we do and have less money than we do. We go through everything, right? Stronger, not as strong. And with obesity, you can't compare yourself to others. I think the most important thing is to recognize with a disease of obesity, you're one of many with the disease. And it really is, we look at each case individually, but at the same time, you're not alone going through this because many people have the same things. And I think too many people believe that it's just me. I'm the only person like this. And in reality, it's very comforting to know that this is routine things that we treat. Okay, we treat this every day. We treat it routinely, we hear too many people say, no matter what the treatment is that we do, I wish I did this sooner. I wish I did it a year ago. I should have 5 years ago. We hear too many people talk about, well, I'm not as big as that person is. I don't have as many health problems. And in fact, many times we do. Some people have more risk of future health problems. And so I think for me, the myth that we have to dispel is that it's not for me, it's for someone else. And really start with that. I'd like to thank everybody here. I think this was a very dynamic conversation. For my colleagues, I know I pushed you hard with some of the questions here. I kind of added a few more that maybe you didn't know about. But I like to challenge you. And I want to ask everyone that's watching this or will watch us in the coming days to talk to someone else about obesity. Talk to a friend, talk to a family member, have the conversation. And I think you'll find that you'll save someone's life. You'll improve someone's quality of life. And it doesn't take much to support someone. I think people just want to know that they're validated that I really do have a health problem from my disease. I can live a healthier life. I can have a better quality of life. And so to me, with Obesity Care Week, with World Obesity Day, that's the big recognition. Okay. Talk to someone else about this. That's why we're here talking to you today. What can you do? Share something on social media. We're going to be posting things all week on our social media and our websites about the disease of obesity. Share it with other people. Let other people know about the disease and the treatments that are available, and know that you may save someone's life down the line. So I want to thank everybody. This was a great conversation. Amy, thank you for organizing this. And I hope all of you out there will hear a little bit more from us and learn a little more this week as we talk about World Obesity Day and Obesity Care Week. So thank you all for participating today.
Thank you.
Thank you.
Good night.
Thanks.